So today we're moving into the next phase, our intrapartum phase, where we're looking at actually having a laboring mother and the delivery of that newborn. So let's jump right in. Okay, as you know, we start off all of our lectures looking at anatomy and physiology. But, when we're talking about labor and delivery, we're not really just looking only at the anatomy and physiology of the reproductive system. We're looking at how that reproductive system serves a certain function, laboring and delivering that baby, right? So we review a lot of that back in the maternity lecture. Make sure you refer back to those notes where we look at the anatomy of the uterus, the placenta, the umbilical cord, and we'll review a good bit of that today too, as it applies to our labor and delivery. Secondly, we have to talk about the different pharmacologic agents that might be used to influence some of that anatomy and or physiology, right? So when we're looking at what sort of drugs we use in this particular specialty lecture, they're mainly going to come in two categories, either a tocolytic or an oxytonic. Tocolytics are medications that suppress premature labor. They are going to relax the smooth muscle of the uterus to hopefully stop contractions. So if a mother goes into premature labor and we want to try and postpone that so the baby can stay in utero a little bit longer, we might use a tocolytic. All right. Think back to that anatomy and physiology. You've got the uterus, which I want you to remember is one big, strong muscle. And that muscle contracts. It moves the baby through the birth canal, helping us deliver hopefully a healthy newborn. So if that's not what we want to happen and we want to relax that smooth muscle and slow those contractions down, a tocolytic is the way to go. All right. Terbutaline and magnesium sulfate are the two most commonly used. So let's talk about each of them. Terbutaline. This is a selective beta-2 adrenergic agonist. Is this ringing a bell for anybody back from your respiratory lecture? You remember when we talked about terbutaline all the way back then? Yeah, because it's a beta-2 adrenergic agonist. Remember, we have beta-2 receptors in the hearts and in the lungs. They're going to help with bronchodilation, right? They block beta-2 adrenergic receptors in that respiratory system, cause that bronchodilation, and also inhibit the release of hypersensitivity reactions, which are formed via mast cells, causing inflammation and narrowing of those airways. All right, so why in the world are we now talking about this beta-2 adrenergic agonist in labor and delivery? Well, it also works on beta-2 receptors that are in the uterus, and that's going to help relax those smooth muscles, slow or possibly even stop premature contractions. All right, so terbutaline indicated for our labor and delivery indication, preterm labor. Now, we do have some nursing considerations to discuss. All right, it can cause some shaky jitteriness. They might get a little dizzy. And remember, with it causing that bronchodilation, we're going to have some vasodilation. That can cause the mother to feel a little bit drowsy or weak. She might get a headache. And it can also cause the blood pressure and blood glucose levels to go up. So hypertension, hyperglycemia are both important nursing considerations for terbutaline. I want you to remember those two, because that really tells you what you need to monitor for in this client. I want you to be monitoring her blood pressure and her blood glucose. Those are two of the really, really big things that can become elevated, and therefore we need to pay close attention to. Let's look at our second tocolytic, our second medication to slow or stop contractions. It's another one that we've already talked about, magnesium sulfate. And technically, of course, magnesium sulfate is an electrolyte. And we talked about it in respiratory for asthma attacks. We talked about it in fluid and electrolytes for treating hypomagnesemia. We know it also has impacts in the cardiac system. When you think back to cardiac, we used it to treat torsade de pointe, that polymorphic ventricular tachycardia that causes serious effects in our client and is due to hypomagnesemia. So now we have another indication for magnesium sulfate, preterm labor. We also use it in eclampsia, or when we have seizures. And that's because magnesium causes vasodilation and relaxation of smooth muscles. So that's why it helps our airways get bigger. Respiratory system, check. That's why it helps in torsades when we have that polymorphic VTAC, relax the cardiac muscle. That's why it helps us in seizures, relax the central nervous system. And lastly, now we see it with our labor and delivery complication or indication, help relax the smooth muscle of the uterus. All right, that's going to slow or maybe even stop contractions. That's why we consider it a tocolytic, and it's very, very common that we see it administered to these mothers. All right, so what I want you to remember is that magnesium causes vasodilation. Blood vessels are going to get bigger. What could that do to their blood pressure? What do you guys think, up or down? Yeah, vasodilation, bigger blood vessels, more room, that's going to cause lower blood pressure. So monitor for dizziness, monitor for hypotension. When she goes from sitting to standing, you might want to be by her side right there just to make sure she doesn't fall while she's getting up, okay? We can have some of that orthostatic hypotension. Okay, now also because those veins are getting bigger, we're going to have that sensation of feeling really flushed. We're getting a lot of blood flow kind of sitting on the surface here. So warm and flushed is a common side effect that we see with magnesium sulfate, all right? And of course, if you administer too much, it could cause hypermagnesemia if we go kind of in the wrong direction here, all right? Also remember that we give electrolytes slowly. Potassium, calcium, magnesium. We don't IV rapid push our electrolytes, especially potassium. There's really only one indication that I asked you to remember when we push magnesium. Anybody remember what that is? Hint, it's on this slide somewhere. We talked about it in cardiac lecture. Go back to that on-demand cardiac lecture if you don't remember. It's that torsades. If we're seeing torsades de pointe, that polymorphic ventricular tachycardia, totally go ahead and IV push 2 grams of MAG. Otherwise, we're giving those electrolytes nice and slow. Okay, so MAG, terbutaline, those are those tocolytics helping slow contractions. Obviously, there are also times where we might want to stimulate contractions, all right? Maybe labor is not progressing. Maybe we need to induce labor or help it along a little bit, all right? Well, in that case, what we need to do is help that muscle contract harder, stronger. I want more contractions. So those medications are called oxytonics, and the most common is, of course, oxytocin. You guys might have heard of oxytocin as Pitocin. That's the brand name. Remember, on the NCLEX, you are only going to get generic names. Okay, so I definitely want you to remember oxytocin. So oxytocin is a hormone, all right? Our bodies make it naturally. It goes to the uterus, it stimulates contractions. Of course, then we have our synthetic oxytocin that we can administer to stimulate that uterine smooth muscle and cause it to contract. All right? 2 big reasons that we give it. We've talked about the first. We want labor to happen. We want stronger, more frequent contractions. The second, treatment for postpartum hemorrhage. All right, we're going to talk about that as a complication of labor towards the end of our lecture today. But think about your anatomy and physiology here, guys. Uterus is connected to the placenta. Blood flow from mom to the placenta, and then through the umbilical cord to baby. And of course, that's how baby gets all of its oxygen, all of its nutrients. It's got to be connected to that blood flow from mom. Now, when a muscle contracts and clamps down, it cuts off that blood flow. All right? So when the uterus contracts and clamps down, no more blood flow to baby. That's okay for a little bit, right? We don't want that to be happening too much too frequently, but that's how labor works. After that baby is delivered, what happens to the placenta? Well, it needs to detach and then be expelled within about 30 minutes of delivery of the baby. Okay? And again, we're going to talk about this in postpartum hemorrhage too. But just think about it here for this pharmacologic agent. After that placenta detaches, we've got the uterus. There's no more placenta there. We basically have a big gaping wound that previously was providing blood to the fetus. And if our uterus doesn't clamp down and cut off that blood flow, there's going to be a lot of blood loss. This is our most common cause of postpartum hemorrhage, when that uterus doesn't contract firmly after delivery. So if we have postpartum hemorrhage and we give oxytocin, we cause that uterine smooth muscle to contract and clamp down, that's going to help stop the bleeding, which is why that postpartum hemorrhage is the second major indication for oxytocin. So what do we need to monitor while we're giving this medication? Of course, the contractions. And if we're giving it for induction of labor, we need to monitor the fetus. Now, how do we do that exactly? we can't really see the baby. We can feel a little bit, but we can't really palpate or auscultate. Really, the biggest way that we have to assess the fetus is through their fetal heart rate and electronic fetal monitoring, okay? So keep an eye out on that fetal heart rate. Watch for bradycardia, tachycardia, accelerations, decelerations. We'll review all of that here in a moment. Now, if the contractions are too frequent and too long, that's going to cause the blood flow to not be sufficient for the fetus. So we'll need to make sure we keep an eye on that. You do need to let mom know, like, this is going to be painful. These are going to make your contractions harder, stronger, and more frequent, which is what we want, but it's not going to feel good. So it's nice of you to let mom know about that. All right, so that's our basics on OB pharmacology. Medications to either slow down our contractions or stimulate them, whether we want them for induction of labor or clamping down on that uterine smooth muscle. So let's say that we're administering it for labor. We are inducing this mother. We are wanting contractions to get going. Let's look at the physiology, anatomy and physiology of this delivery process. We first have to just look at the position of the baby in the uterus, okay? So remember, mom's uterus connected to placenta, placenta to umbilical cord to baby, and that's how we're getting blood flow. All right, this baby can be in several different positions within the uterus. And we've got a nice little mnemonic system here to help us identify that position. It's 3 letters. The first letter will be either R or L, and that simply tells us which side of the mother's pelvis that baby is on. Is it on the right side or the left side? Simple. Now, the second letter tells us about the presenting part. What's the presenting part here? That is the part of the baby facing the birth canal. So I want you to think about what part of that baby is going to come out first, present itself to the world, all right? That could be an O for occiput, which of course the occiput is the back of the head, and that's what we want to see. It could be an M for mentis. The mentis is the chin, and that would happen if the baby is hyperextended and that chin is looking out of the birth canal. And lastly, it could be an S for sacrum if the baby is breech and their buttocks is presenting out. All right, so right or left side of the pelvis, occiput, mentum, sacrum, which part is facing out. The very last letter then tells us if the baby is in the anterior, posterior, or transverse part of the mother's pelvis. So our first letter looked at right or left. Our third letter is basically looking at front or back. Anterior, they're in the front. Posterior, they're in the back. And if we see a T for transverse, that means that baby is horizontal, all right? They are not vertex up or down like we want them to be. They are side to side. They are in a transverse position. And is that going to really help us with labor? It's going to be pretty challenging for a smooth, spontaneous vaginal delivery, right? Of course, not impossible. Plenty of mothers have delivered with different presentations, but it's certainly going to be more difficult. And it makes sense when you look at that anatomy, right? It makes sense when we look at what is the easiest path for this baby to exit the birth canal. So any guesses from you guys on what the most common and what preferred position we have for this fetal presentation? Nice, absolutely. ROA. ROA or LOA. So on the right anterior with the occiput presenting, or the left anterior with the occiput presenting. Either of those are going to facilitate a natural, spontaneous vaginal delivery. It's just the position of the baby that's most amenable to that pathway, all right? Now, for some reason, LOA is a little bit more common than ROA, but they are both really good positions, okay? Now, ROP, LOP, those are both pretty common and easy as well. But when we start getting into a sacral presentation, or if the baby's hyperextended and we see the mentis presenting, or of course, any of those transverse presentations, that's when we're going to start to see a little bit of a more challenge. Okay, so the next part of this anatomy is looking at the station. How far down does the baby actually go in the birth canal? This is measured in centimeters relative to the ischial spine. Okay, the ischial spine, if you kind of shift back and forth, you can kind of feel those bones that your pelvis has, right? Those are your ischial tuberosities, all right? And if I get my little pointer out, you guys, you can see those ischial tuberosities right here, all right? So that's what you can kind of feel when you kind of shift back and forth a little bit. And between those ischial tuberosities, that is the most narrow part of the pelvis. So when the baby is 1 centimeter above them, we say they are at -1 station. If they, have to sneeze. Sorry. If they are at -2 centimeters above those ischial tuberosities, that ischial spine, then they are at -2 station. Once they pass through that most narrow part of the spine and they start descending lower into the birth canal, we measure it in positive centimeters. So 1 centimeter below, they're +1, 2 centimeters +2, +3. That's when we hear people say the baby is crowning. Now, that's just a term that means that we're starting to see the baby's head, all right? The crown of their head is presenting, they're at +2, +3 station, and we're starting to be able to actually see that baby. So we know we're very close to delivery. All right, and as we've talked about all of this anatomy and physiology, the progression through the birth canal, the presentations, one of the big things that we've been talking about monitoring is the baby. And remember, we can't see the baby, we can't really feel or listen to the baby. So the biggest way we can assess them during labor and delivery is through fetal heart rate monitoring. Okay, we went over this in our maternity lecture as well. So for my on-demand students who've already watched this and you're pros, you might want to skip through this recap. That's okay. But for those of you joining with me live today, I want to review fetal heart rate monitoring again. This is an essential component of both the antepartum process, like we talked about in maternity, and the intrapartum process during labor and delivery, because it's the only way we can keep tabs on this baby. So there are 3 main things you guys are going to be watching out for when you're monitoring that fetal heart rate, okay? You're going to be looking at variability, and that's the fluctuation in the fetal heart rate, going up and going down. You're going to be watching out for accelerations, a speeding up of the fetal heart rate. It's accelerating. And you're going to be watching for decelerations, a slowing down or a deceleration in that fetal heart rate. When we see things that are good and tell us baby is healthy, woohoo, we say that that's reassuring. When we see things that are bad and make us worried, that is non-reassuring. So that's the lingo that you're going to hear people use when they talk about fetal heart rate monitoring. Now, one important component is to know what the normal baseline fetal heart rate is. Any of my live students know? What do we think? Yeah, 110 to 160. All right, 110 to 160. So fetal bradycardia less than 110, fetal tachycardia greater than 160. Super. All right, and that comes into play when we look at this first component, our variability. Is it absent, marked, or moderate? Remember, variability is the fluctuation in the fetal heart rate. Absent variability is bad. You see this baby's heart rate, it's at about 120 right here, which is an appropriate fetal heart rate, but it doesn't have variation. It doesn't go up and it doesn't go down. That absent variability is a bad thing. On the flip side of this coin, we can have marked variability, all right? This baby's heart rate, it looks like it's somewhere in the middle here, maybe at about 130. But look, it's going all the way up to 150 at times, and then all the way down to 120 at times. It is really varying a lot of variation. Marked variability, it can be bad, or it can be good. It depends on what's going on with this baby. Is this mother in active labor, 10 centimeters, station of +3? If she is, and delivery is going to happen soon, well, then this is a good thing. Baby is really active. It's a really active situation. But if mom is just taking a nap on the couch and this baby's heart rate is going up and down this much, we need to figure out why. Something else is going on here. So absent bad, marked, can be good or bad, depends on the context. What we usually have and what we really like to see, we refer to as moderate variability, all right? This baby's heart rate looks like it's about at 120, 125, and it's varying about 10 points up and down between 120 and 130. This is a moderate amount of variation, moderate variability, and this is what we like to see. Moderate variability is a reassuring sign. All right, next we have our accelerations. This is a speeding up of the fetal heart rate. And I always remember accelerations are A-OK. We like to see a speeding up of the fetal heart rate. And they happen in time with contractions. So if the NCLEX gives you a fetal heart rate monitoring strip, it will likely look something like this. The lower strip down here has contractions. There's contractions here, she's having one here, a third one here. And you see with this first contraction, the baby's heart rate up here went up, stayed up, and then came back down. We call that an acceleration. And we monitor accelerations by the increase in beats per minute of the fetal heart rate and how long they stay elevated for. So here we see this fetal heart rate went from about 120 to 150. It went up about 30 points, and it stayed elevated for about 15 seconds before coming back to baseline. That was a 30 by 15 acceleration. If you remember back to your maternity lecture when we talked about antepartum testing, we were monitoring for accelerations during a non-stress test. And does anyone remember how high and how long the acceleration should have been? What were we looking for? That's right, 15 by 15. We wanted to see an increase of 15 beats per minute for 15 seconds in our accelerations. So make sure to review these for that non-stress test and contraction stress test. That's an important part of antepartum. Now, the last thing you'll be monitoring for in the fetal heart rate strip are the decelerations. And we have three types: early, variable, and late. Early decelerations happen at the same time as contractions. So when you look here, we have a contraction, wonderful. And at the same time, that baby's heart rate slows down. It decelerates. Early decelerations happen because of head compression. Let's think about what's happening here when we look back at our anatomy and physiology. We've got a uterus that's contracting and squeezing that baby and pushing them through the birth canal. Assuming we have a vertex presentation with the occiput as the presenting part, when mom has that contraction and the uterus compresses baby and pushes them down, it makes sense that their head is going to be compressed. The compression of that head is essential for progressing labor. We need that to see dilation and effacement occurring. But that head compression can stress baby out a little bit. And we can see that their heart rate goes down a smidge. The important thing to note here with early decelerations, not only do they happen at the same time as those contractions, they also come back to baseline right after the contraction ends. This isn't prolonged. It's just happening while we have that head compression. Additionally, look at the variability. What would you guys classify this variability as? Absent, marked, moderate? I would say this is moderate variability. Moderate variability is a reassuring sign. These early decels occurring with contractions, I bet you this mom is in active labor. So is this a reassuring or non-reassuring fetal heart rate strip? Yeah, I would say that this is reassuring. My early decelerations, they are not going to cause me too much worry as long as this mom is in active labor. All right, again, if she's napping on the couch right now, I want to kind of figure out what's going on here, okay? But if we're in active labor seeing these early decels, it's not uncommon. The two decels that really worry me are variable and late. Let's talk about variable first, okay? These also happen with contractions, okay? We see contraction here, deceleration here, contraction here, deceleration here. What's the difference? Early, here's your decel. Variable, here's your decel. It's the shape, right? It's how fast this fetal heart rate plummets and then pops right back up. In a variable decel, we see like a spike. That heart rate drops. It's not a gradual deceleration. It is like slamming on the brakes, all right? We went from a heart rate of 150 all the way down to about 80, which is fetal bradycardia. And then as soon as that contraction ended, the heart rate spiked right back up. All right, so what would cause this dramatic drop? Well, we know that the baby gets stressed out when they don't have blood flow. So if we have a severe cutting off of blood flow all of a sudden that baby's not getting oxygen and that heart rate dips down really low, it's going to cause a variable deceleration. The physiologic process that causes this is cord compression. So remember back to that anatomy, the placenta is what gets blood flow from mom. It connects to the umbilical cord, brings that blood flow to baby. And if that cord gets compressed, it's like kinking off a garden hose, right? No more water's coming out. No more blood's going to baby. All right, baby's not getting blood, baby's not getting oxygen, heart rate plummets. All right, then our contraction ends. The cord isn't compressed anymore. You let go of that garden hose. Water comes flying out. That baby gets reperfused with blood super quickly, and their heart rate rebounds rapidly. So when we have cord compression, and we're going to look at several L&D complications that can cause this, we can have variable decelerations. Additionally, look at the variability in this strip. Look at this fetal heart rate. Look at that variation. Would you all classify that as absent, marked, or moderate? I see it's at about 140. Again, that's a normal fetal heart rate. But I'm not really seeing variation above or below 140. There is absent variability here. So is this reassuring or non-reassuring? I'm worried about this. Absent variability, variable decelerations. This makes me think that there is a labor and delivery complication going on and that the baby is in trouble. So this is non-reassuring. Okay, our last non-reassuring sign in a fetal heart rate strip are those late decelerations. All right, so now when we look at mom having contraction starts, ends, and then we see the deceleration start. So with early decels, they happen at the same time. With late decels, they happen late. Simple. All right, this is due to placental insufficiency. The placenta is not getting enough blood flow for one reason or another. We'll talk about many complications that can cause that. And when that placenta doesn't get enough blood, baby doesn't get enough blood. And we start to see those late decelerations. This is a non-reassuring sign. This definitely makes me worried about baby. All right, so if you're struggling to remember all those different signs that we just went through and what their causes are, try this little memory trick out. Veal chomp. V for variable is caused by C for cord compression. E for early, that's caused by H, head compression. Remember, our accelerations are A-OK. And lastly, your late decels are caused by P, placental insufficiency. Okay, so if you don't remember anything else, just jot this memory trick down when NCLEX day comes. And if you see one of these types of decels, A-cells, well, then you can remember what causes it, which is going to be essential for figuring out what your priority nursing interventions are. So just to recap, what we're wanting to see is a reassuring fetal heart rate strip. That is a fetal heart rate of 110 to 160 with moderate variability and accelerations. Non-reassuring fetal heart rate strips are tachycardia or bradycardia accordingly, that decreased or absent variability, those variable decels, and those late decels. I see any of those things, I'm worried. I am not reassured. It is non-reassuring. If I see any of those things, I have to know what to do about it. So this is the big thing that I see tested on the NCLEX when it comes to fetal heart rate monitoring and intrapartum. Your mom is in labor. You start seeing one of these non-reassuring signs. What do you do about it? What is your priority nursing action? Okay, we've got this memory trick here, lion pit. This is not in order of prioritization, all right? That is just a way to help you remember all of the different possible interventions. You're going to have to use some critical thinking to figure out which of these is the priority. But if you remember your anatomy and physiology, and you understand what these interventions do to that anatomy and physiology, you're going to have no problem with that. Remember, placenta, blood flow to mom, connected to umbilical cord, blood flow to baby. That's how baby gets oxygen. Baby gets oxygen, and we'll see a reassuring fetal heart rate strip. Baby doesn't get oxygen, doesn't get blood flow, and we start to see these non-reassuring signs. So every single one of these interventions is aimed at one thing: increasing blood flow and therefore oxygen to baby. Every single action that we take is about getting that baby oxygen. And if we do that, their heart rate should come back to normal. Now, which method of getting more blood flow to baby, more oxygen to baby, is our priority depends on the problem. So let's look at each of these interventions. Laying the mother on her left side. Well, this helps get more blood flow to baby because it increases blood flow to the placenta. This is the best position for expecting mothers to get good blood flow to that placenta. Why can't they lay supine on their back? What if that's where they're comfortable? Well, all of that pressure can compress their aorta and decrease blood flow to baby. So we do not want expecting mothers to lie supine, left side lying. Now, increasing IV fluids. This increases blood flow to baby because it increases the mother's blood pressure. Remember, more volume, more pressure, more blood flow to placenta, more blood flow to baby. Oxygen increases oxygenation to baby because if mom has more oxygen can go to baby. And notify the healthcare provider. We do this when nothing else that we can do will help the mother. And lastly, PIT from Lion Pit is discontinuing the Pitocin. All right, now this helps increase blood flow to baby because if we're administering oxytocin and it's causing frequent intense contractions, remember those contractions clamp down on blood vessels, cut off blood flow, no blood flow to baby. Too many contractions, not enough blood flow, we can start to see these decelerations. So discontinuing the Pitocin will help have less contractions, less cutting off blood flow, more blood flow to baby. So let's talk through some scenarios here together about prioritization, because really we get a lot of NCLEX questions asking us to prioritize these actions. It would be great if there was a little memory trick that had all of them in order, but we can't do that because the priority depends on the situation. All right, you have a client. They are 10 centimeters dilated, active laboring, and you start to see late decelerations and decreased absent variability on the monitor. So you go and you check mom's vital signs. All right, she has a heart rate of 110, a blood pressure of 82/57, a oxygen saturation of 95%, and a respiratory rate of 18. Okay, based on those vitals and the fetal heart rate monitoring strip, I want you to pick from these 5 choices, what is your priority nursing action? Excellent. The vital sign that was concerning was her blood pressure. She is hypotensive, which means less blood flow getting to baby. This is a problem, and it's causing placental insufficiency, which is causing late decelerations. Which of these interventions can increase blood pressure and therefore blood flow to baby? Increasing the IV fluids. So in that example, my priority nursing action would be increase the IV fluids. All right, let's try another one. You have a mother who they're not in active labor yet. Maybe they're being monitored antepartum for a non-stress test or a stress test. And you come into the room, you know that mom looks quite comfortable. She's napping. She's laying on her back. She's got all her pillows. Her vital signs are all within normal limits. She looks really cozy in there taking a nap. But when you look at the fetal heart rate monitor, once again, you see late decelerations. All right. Do you increase IV fluids, give oxygen, notify the provider, give Pitocin, or lie the mother on her left side? In that scenario, what is your priority nursing intervention? That's right. She's napping on her back. Oh, she's asleep. She's comfy. I don't want to wake her up. But all of that pressure is compressing her aorta and decreasing blood flow to baby and causing placental insufficiency, which is causing late decelerations. I have to lie her on her left side to increase that blood flow to baby. All right, so does this make sense to everybody and help you figure out how to prioritize these interventions? You know what they are. You know how they help increase blood flow to baby. And now when you go through one of those scenarios, you're going to think back to that anatomy and physiology, and you're going to know what you need to immediately do. So let's talk about when we should notify the healthcare provider. All right. One of my test taking strategies to you guys is that if there's something you can do for your client, I want you to do it. Mom's napping on her back and you can turn her to her left side. That's your priority. Mom has hypotension and you can increase her IV fluids. Do it. If there's something you can do it. They want you to fix the problem. If there's not something you can do to fix the problem, though, that's when you need to notify the healthcare provider. So there are several of our L&D complications we're going to talk about where that's the only thing possible. The first one that we're going to discuss is called an abruption. If your client has an abruption, we're out of luck, all right? Lying her on her side, increasing IV fluids, giving oxygen, none of that's going to fix the problem. So that's when we need to notify the healthcare provider. And as we go through each of our labor and delivery complications, we'll talk about what our priorities are. So the first complication to discuss, we're going to talk about placenta previa. Then we're going to talk about that abruption. We're going to talk about prolapsed cord, postpartum hemorrhage. We've got a lot to go through, but we've been lecturing for about an hour. So I'm going to give you guys a quick 10-minute break for those of you who are with me live. If you joined in on demand, feel free to skip through this break or, perhaps take a quick break yourself. For those of you who are on with me live during our 10-minute break here, I invite you to check out our private and small group NCLEX tutoring. The first one we're going to talk about, pretty common one you may have heard of before, is called placenta previa. And as long as you know your normal anatomy and physiology, this one is pretty straightforward to understand. Placenta previa means that instead of the placenta being up in the fundus of the uterus like it is supposed to be, why is this? Hold on, let me make sure my slides are working for you guys. Give me a second. There we go. Good job. Internet was lagging on me there. So instead of that placenta being up in the fundus like it's supposed to be, it's actually covering the cervix. All right, so quick review. We've got uterus, placenta, umbilical cord to baby. This baby is in a nice vertex presentation. The occiput is the presenting part. And then we have the cervix here, which is usually closed, keeping the outside world separated from the uterus. As that head compresses, it's going to cause dilation and effacement, so that cervix opens up. And the baby can go through the vaginal canal, make its wonderful appearance into the world, right? If the placenta is covering that cervix, well, that's going to be pretty hard to do, isn't it? Think of it like a roadblock. The baby has a physical roadblock that is not able to exit the birth canal. So what you're going to see if you assess a mother with placenta previa is that she has painless, bright red bleeding. And the fact that it is painless is key because the complication we're going to compare it to here has very, very painful bleeding. All right, that sets it apart. When you assess this mother, you want to assess the bleeding. It's going to be bright red, and you're wanting to assess how much bleeding she's having. Usually we do this with something called pad counts. All right, so we'll have pads. We'll count how often she is saturating those pads. All right, you want to look at the color of that blood and if there's any clots in it as well. How is this diagnosis confirmed? With an ultrasound. We cannot ever, ever, ever put anything inside the vagina of the client who has placenta previa. I don't want you to do an exam. I don't want you to do a transvaginal ultrasound. I don't want that mother to have a spontaneous vaginal delivery. Why? Look at that anatomy. What are you going to touch if you do a vaginal exam? The placenta. And the placenta is doing what? Bringing blood to the baby. So I surely do not want to irritate that. I do not want to do anything that's going to irritate the placenta. So all we can do is monitor this mother's blood loss. We're going to put her on bed rest. We're going to do pad counts to see how much blood exactly she is losing. We're going to monitor that baby, watch for any decelerations. And when it comes time for delivery, this mother is going to need to have a C-section because there's just no way for that baby to be delivered vaginally if there is a roadblock. Okay, now the other very common complication tested frequently is called abruptio placentae. Now, this is contrasted from previa. It's still a placental problem, but instead of the placenta being in the wrong place, this is where the placenta actually detaches. All right. So this placenta was in the fundus. It was in a really good spot. And something happened where it ripped away from the wall of the uterus, either partially, like we see going on in this photo, or it gets fully ripped away from the wall of the uterus. Now, what was the purpose of that placenta? Blood flow to baby. It's very vascular. A lot of the maternal blood flow is going to that placenta. It gets ripped away. We have massive hemorrhage. If it's ripped away from the uterus, placenta not connected to mom, what can baby no longer get? Blood, and therefore oxygen. Mom is hemorrhaging, baby has no oxygen. This is an emergency. This is one of the most critical labor and delivery complications to be aware of. This mother is going to have massive hemorrhage. It's going to be dark red bleeding, and it is going to be painful. Super, super painful. Now, if that placenta only partially tears away from the wall of the uterus, we call it an incomplete placenta abruption. And if it tears all the way away from the wall of the uterus, we call it a complete abruption. Now, incomplete abruption can cause internal hemorrhage. Complete abruption can cause external hemorrhage. So you'll see some different symptom findings, assessment findings, depending on the type of abruption for sure. Now, if that is internal hemorrhage, we've got blood backing up in the abdomen. We're going to have intense abdominal pain, a board-like abdomen, a rigid uterus, and we may see that fundal height, the height of that fundus when we measure, increasing because we're having so much blood flow back up. With that external hemorrhage, you're going to see that dark red bleeding. Either way, this mother is going to become hypotensive. Why? Losing blood volume. Less volume, less pressure. Hypotension can lead to shock. Low pressure, we cannot get blood out to the tissues. The tissues don't have oxygen. Deficit of oxygen at the cellular level is shock. So placental abruption can cause hypovolemic shock. This means not only do we need to monitor baby, we need to monitor mom's vital sign, blood pressure, heart rate, for shock. As that blood pressure dips down, her heart rate may go up to compensate compensatory tachycardia. And of course, on that fetal heart rate strip, we may see fetal bradycardia, decreased or absent variability. We may see late decelerations due to placental insufficiency. This is probably the most dramatic way to have insufficient blood flow to the placenta. All right, so what do we want to do about this? I told you earlier, our priority nursing intervention is getting the healthcare provider. Because here's the thing, giving her IV fluids, giving her oxygen, laying her on the left side, well, all of these things may kind of help a little bit. Are they going to fix the problem? No. That placenta has torn away from the uterus. The only thing fixing this is an emergency C-section. Otherwise, mom and baby are going to die. So our priority is we're going to get that healthcare provider. We are going to get mom to the operating room. As we're doing that, great idea to give her some IV fluids, keep that blood pressure up, prevent shock, monitor that bleeding, monitor the baby, and get them out. That's really the key here, is that emergency C-section. All right, let's try an NCLEX question together. I want you to think back to the testing strategies we've been using throughout this review course and try to apply them here, all right? Put this question in your own words, ask yourself what it's really asking you, and look at each of these answer choices as true or false questions. I'll give you a minute, and then I'll walk you through it. All right. So when I read this question, I see we have a new client, antepartum. They started bleeding this morning, and it's painless. They're denying any pain or other symptoms. Which interventions do I anticipate initiating? All right, so when I'm putting this question into my own words, I need to use some critical thinking, because this question isn't just asking me what are interventions for bleeding. All of these signs together are making me think placenta previa. Painless bleeding, placenta previa. So when I put this question in my own words and I say, okay, Morgan, what the heck are they actually asking me? What I say are, which interventions are appropriate for placenta previa? And then I put it into true, false, all right? True or false, is bed rest appropriate for placenta previa? True, pick it. True or false, are pad combs appropriate for placenta previa? True, I'm gonna pick it. C, is an emergency vaginal delivery appropriate for placenta previa? False. We cannot vaginally deliver this infant. They have a roadblock going on. False. I'm not going to pick it. D, a vaginal exam. Same answer. False. And lastly, E, is an ultrasound appropriate for placenta previa? True. That is how we diagnose it. A, B, and E. So I know that select all that apply is really scary. We don't like select all that apply. I don't blame you, but they are truly just true or false questions. Simplify them, use those testing strategies, okay? And remember, we've got lots of select all that apply small groups if you really struggle with them, okay? Next emergency is a prolapsed umbilical cord. What this means is that before the client's amniotic sac has ruptured and we've had their water break, rupture of membranes, the umbilical cord actually slips through the cervix and into the vagina. All right, when this happens, when the membranes do rupture and the baby descends down into the birth canal, their presenting part is going to be compressing the umbilical cord. Look how that baby's head is just sitting right on the cord. That cord compression completely cuts off blood flow to the baby. Baby gets no oxygen, and this is a cause of potentially variable decelerations because we have cord compression. When we assess this client, you're going to see that umbilical cord protruding through the vagina. If you go to do a cervical exam, you might see the cord, something squishy, pulsing, or mom might call you into the room and say, like, hey, like I feel something really weird between my legs. Like, can you check me? I don't know what's going on. It's not a baby, it's an umbilical cord. We have a prolapsed umbilical cord. Okay, so what do? Your priority nursing intervention is to elevate the presenting part of the fetus off of the prolapsed cord. Not lion pit, not notifying the healthcare provider. There's something you can do to help the client here, and it's elevating the presenting part. When you look at the picture, it makes sense as to why, right? That head is squishing down the cord, cutting off blood flow. If you lift it up, we get blood flow back, right? The cord's no longer compressed. Blood flows from the placenta through the cord to the baby. Baby gets oxygen, and they're happy as can be. This temporarily fixes the problem. So this is our priority nursing action. Now, as soon as you do that, you're going to call for help, get somebody else in the room, and your nursing friends are going to start doing some other things that can assist us here. There are two positions that help. Knees to chest opens the pelvis a little bit, and then Trendelenburg, head down, legs up. That's going to help shift the baby off of that cord a little bit, right? And let gravity help us out. Now, we can give the mom oxygen, more oxygen to mom, more oxygen to baby. We also need to wrap that cord in a sterile, moist towel so that it doesn't dry out and end up having poor perfusion. We want to make sure blood is flowing through there very, very well. All of this is just in the meantime as we roll mom back to the operating room for an emergency cesarean section. It is not safe for this mom to push and deliver vaginally. Why? Well, that baby's head is going to just keep compressing that cord. They're not going to get oxygen. They're going to have variable decelerations and be in distress during the delivery. We don't want to do that, all right? So if you are the unfortunate nurse who walks into the room to do this assessment, you see that prolapsed cord, you are going to immediately lift the presenting part and call for help. You're now stuck. You can't move, all right? You cannot let go until the OB does a C-section and takes that baby out. Because if you set them down, you're setting them down on the cord and causing cord compression, all right? One really key thing that I do see tested on sometimes are if we are allowed to push the cord back in, and we are not. Never, ever, ever attempt to push the cord back in. This can cause what we call like an occult prolapsed umbilical cord where you can't see it, but it's still there. And it's much harder for us to keep the baby off of that cord. So we don't push it back in. We just lift them up. All right, so what type of decelerations will we be seeing here? Variable. We will be seeing variable decelerations. In abruptio placentae, what type of decelerations could we be seeing? Late decelerations, right? In abruptio placentae, we have placental insufficiency, not getting enough blood flow. We're going to have late. In prolapsed umbilical cord, we've got cord compression. We're going to be seeing variable. What about placenta previa? Are we going to be seeing decelerations in placenta previa? No, I would not expect that because the baby's still getting blood flow. The placenta is just in the wrong place. It's in the wrong place. So with placenta previa, that placenta is covering the cervix. We can't see it protruding from the mother's vagina though, all right? It's all internal. We're not going to actually see it. They're just going to be having bright red, painless bleeding. In a prolapsed umbilical cord, we're actually going to be able to see the cord. It's the cord that comes through the vagina. It's protruding. We're going to be seeing variable decels. We're not going to be seeing bleeding. Bleeding is not something we expect in a prolapsed umbilical cord. All right, so those are three of the biggest L&D emergencies right there that you are sure to see on your NCLEX. And hopefully now you can remember those very specific assessment findings. Next, I want to talk to you about not one of these fancy dancy ones, but the most common postpartum complication, hemorrhage. All right, you've all heard of postpartum hemorrhage. So we've talked about all of these different crazy complications during labor, but now we're looking at after the baby's been born, got a happy, healthy newborn, hopefully, what can go wrong postpartum period with mom. And while there are many, many, many things, the by far most frequently tested on the NCLEX and most common postpartum complication is hemorrhage. So some moms are at higher risk for postpartum hemorrhage than others. If there are multiples, twins, triplets, etc., that's going to increase the risk. If the baby is really, really big, a macrosomic fetus. Think back to your maternity lecture for me. What prenatal complication can cause a macrosomic fetus? That's right, gestational diabetes. Gestational diabetes is one of those antenatal complications. It can cause intranatal complications with a difficult labor, and then it can cause postnatal complications with high risk for postpartum hemorrhage. A macrosomic fetus is a baby greater than 4 kilograms, all right? Greater than 4 kilograms. All right. Preeclampsia, another one of those prenatal conditions that we talked about. Prolonged labor or precipitous labor. When we talk about precipitous labor, it's a labor that happens very, very, very quickly. If the physician uses an assistive device like forceps or a vacuum during labor, both of those increase the risk that we will have actual tissue damage to the mother and that can cause hemorrhage. And then we have those two complications that we saw caused hemorrhage, placenta previa with that painless bleeding, abruptio placenta with that painful bleeding. All right, so of course you're going to be assessing the bleeding. You're going to be palpating the mother's uterus, that fundus, all right? And what you want to feel is that it's nice and firm. Why is that? Well, we mentioned that after that placenta detaches from the uterus, it leaves a big gaping wound there that has a lot of blood flow because that's where the baby was getting blood. Now that the placenta is not there anymore, the mom's going to be losing blood from that wound in the uterus. Well, we need the uterus to clamp down, contract really hard, so that it cuts off that blood flow and stops the bleeding. And when the uterus is contracted, we really feel a very firm uterus, right? So if we don't feel a firm uterus, we refer to that as boggy, a soft, boggy uterus. That tells me that the uterus is not contracting. And if it doesn't contract, that mother's going to be hemorrhaging, all right? So when you go to palpate and feel that uterus, you might feel that it's boggy. All right, now let's talk about assessing their blood loss, all right? We talked about pad counts for placenta previa. Most of the time, if you have postpartum hemorrhage, they're saturating a pad every 15 minutes. Anything greater than 1 pad an hour is a problem, all right? That's too much blood loss. It might be so much that when the mom goes to maybe stand up and go to the restroom, there's a puddle of blood in the bed. Also really common when she stands up for the first time. Think about it. If she's been lying supine, maybe she's been hemorrhaging and it's just been collecting in her uterus. They go to stand up and there's just a gush, all right? And that blood loss is going to cause their blood pressure to go down and they could pass out and hit the floor. So when moms are getting up for the first time, you're going to want to be there to help, okay? If they lose so much blood that their blood pressure goes down, we are going to be worried about hypovolemic shock. Low blood pressure, increased heart rate to compensate. They're going to be pale, cool, clammy, diaphoretic. All those signs of shock that you guys already know, all right? You're going to be on extra high alert, watching out for those clients that you know are at high risk based on those postpartum hemorrhage risk factors. So what are we going to do about this? All right, we mentioned that the uterus needs to contract. So the first least invasive thing that we can do is called a fundal massage, okay? we are going to really dig into that uterus and try to physically get that muscle to contract. Now, let the mom know that this is going to be painful, and I'm really, really sorry, but we absolutely have to do it. We have to get the uterus to contract so that that bleeding stops, all right? At least every 15 minutes, all right? You also want to be monitoring that blood loss. We've talked about pad counts, but what if you want a more exact measure? Then you're going to actually weigh those pads. So if you weigh a pad and it's 15 grams, that's 15 milliliters of blood that's lost. In a vaginal delivery, now, clearly you're going to lose some blood. Anything greater than 500 mLs counts as a postpartum hemorrhage. So we want less than 500 in a vaginal delivery. And if the mother has a cesarean section, she can lose up to 1,000 milliliters or 1 liter. Okay, so we give them a little bit more wiggle room if they've had surgery. All right, but anything greater than those numbers, that is a postpartum hemorrhage. And we're going to be making sure to watch for that really closely, because the more blood they lose, the higher risk for shock. Another thing is that if they're losing blood, they're losing red blood cells, and that can cause anemia. Their hemoglobin and their hematocrit, a lot of us call that H and H, will be trending down. And depending on the client's baseline, if it's less than about 7 for the hemoglobin, it's quite common that the mother will receive a blood transfusion. Now, in addition to that bundle massage, if we've got a really serious hemorrhage going on, we're going to give the mother some medications. We've got 3 big medications. First, oxytocin. Okay, now you guys by this point, you understand why we're giving oxytocin. All the way back to the beginning here, bringing it first full circle, we talked about giving oxytocin to help the uterus contract. That was why it was indicated in labor, to help induce labor, and also why it's indicated in postpartum hemorrhage. When the uterus contracts, it clamps off that blood flow, we stop the hemorrhage. Okay. The second medication that we can give is called methylergonamine. This is a group of drugs that we call ergot alkaloids. You don't need to remember that. That's a little bit too much for the NCLEX. But what methylergonamine does is affect the smooth muscle of the uterus, improve its tone, make it firm, cause strong contractions. All right. So right after the baby's born, if that placenta detaches, we start hemorrhaging, we can give that methylergonamine to cause that uterus to contract. All right. We can give that oxytocin to cause that uterus to contract. And if they lose a significant amount of blood, remember, monitor that hemoglobin and hematocrit. That third medication is giving them blood products, giving them a blood transfusion. All right. So this is for another lecture, but this is one of those times where the NCLEX could ask you a pharmacology question that also has some safety and infection control implications about who can administer a blood product. Those different things that you have to make sure happen when you are administering blood products. So of course, it's always the registered nurse, the RN. We need 2 RNs to double check that client's name, blood type, and verify that it's the correct transfusion. We need to get vital signs before when that transfusion starts, 15 minutes into the transfusion, and at the completion of the transfusion. It's okay to delegate the collection of those vital signs, but the registered nurse needs to be there evaluating, okay? I never leave my client's room in those first 15 minutes, really 30 minutes that I'm giving a blood product, because I want to watch out for a reaction, right? So make sure to review that, because this is one of the complications. The NCLEX could throw a blood product question your way. All right, let's recap those labor and delivery complications, okay? Back in maternity, we talked about all of your antenatal high-risk pregnancy complications. Make sure to review that on-demand lecture. Today, we talked about all of your intranatal complications. We had a prolapsed umbilical cord. We had placenta previa, where that placenta was covering the cervix and stopping that baby from being able to leave the uterus. Then we had a placental abruption, where the placenta actually tore away from the wall of the uterus and caused massive hemorrhage. And of course, that prolapsed cord, where the umbilical cord actually slipped into the birth canal and the presenting part of the fetus compressed that cord, cutting off blood flow. After delivery, we had our postpartum complication. We just finished that postpartum hemorrhage. So now you guys know the risk factors for it, how to assess your client, and of course, those major interventions that you will be able to implement to stop that hemorrhage. All right. I thank you guys very much for joining our labor and delivery